prostate cells. And so it's not 100% accurate for detecting prostate cancer. However, when the concentration of this prostate-specific antigen, as it's called, PSA, when the concentration of that protein starts to rise in the blood, it begins to become more significant. And there it follows that there's a stronger correlation or association with developing prostate cancer. Currently, the figure that is seen as being significant is 4 nanograms per mil. So if you do have a blood test for PSA and you have to phone the surgery to get your results, ask for the actual figure, because the receptionist will often come back more. Now, it's really important that you get the number, because what you should do once you start having the PSA test, you should go back every year and request the repeat test. Make a note of that number that you're given. It might be 0.4, 0.8 or whatever nanograms per mil. And when you get your next test a year later, look to see if the number's gone up. Because if the number's gone up, you should go back to your GP and have a conversation and say, look, I've noticed the figures crept up a little. Can you just perform another test? Or do I need referring? Now, if you get a PSA level above, so namely 4 grams per mil or higher, then the GP will refer you to hospital to see a urologist. And the urologist will perform scans, imaging in your pelvic region, looking at the shape of the prostate gland and looking for shadows on the gland itself, and also looking at other tissues and other organs in that region to see whether the cancer has possibly spread to other regions. It could be that they find nothing wrong, in which case you'll be sent away with advice to come back maybe in the future. However, if they do find something that looks a bit suspicious, then you're likely to have a biopsy performed. And that's when a needle is inserted into the prostate gland itself, and small pieces of tissues measuring 2 millimeters in diameter across is removed. Now, it's common to have 10 to 12 biopsies taken from your from your prostate in order to sample the whole area of the prostate gland. Unless something can actually be seen on the imaging, then it's a bit hit and miss to actually pick up cancer. So that biopsy tissue will then be sent to pathology. A pathologist will examine it to look at the distribution for abnormal cells. And they'll work out a score called the Gleason score. And this is a measure of abnormality. So if you get a Gleason score, it means that the chances are there's a cancer which is visible, and the higher the score, then the more aggressive the cancer is likely to act in the future. Okay? So armed with that information, your clinician will have a discussion with you to talk about the treatment pathway that you're going to go along. If it's a low-grade cancer, it might be decided not to give any treatment whatsoever, but perform what's called watchful waiting, whereby you'll be called back at regular intervals and you'll have a repeat PSA test in order to see whether there's any increase in the protein. You might be called for more imaging just to check that nothing else is happening down below. Or some people don't like the thought of living with a cancer, and they might decide to have hormonal treatment. And the purpose of hormonal treatment is to neutralize male hormones called androgens. These are produced in the testes, and a good example is testosterone. And this particular hormone is responsible for promoting growth in the prostate gland. So if you repress that hormone, then you're going to slow down the growth of any cells within the prostate gland. Having said that, some people still don't like the idea of still having cancer, or the type of cancer could actually be life-threatening in the future. So therefore, a curative procedure will be performed. And that's to remove the prostate gland itself by surgery. And there's a couple of different surgical techniques that can be performed. Or radiation therapy might be given to the local area around the prostate region to kill off the gland. Now, the prostate is situated in a very important position in the body, as you can imagine. It's close to the testes, it's close to the penis, close to your bladder. And so if you start bombarding that area with radiation or perform surgery, then unfortunately you are at risk of developing some side effects, unwanted side effects. These can include incomplete loss or partial loss of bladder control. So you might experience some urinary incontinence, might be temporary, might be long lasting. Also, erectile dysfunction can occur. So the ability to maintain or to achieve an erection is a distinct possibility. So therefore, some men opt for more conserving treatments. And there's an increase in the amount of techniques which are now available to try and preserve and conserve these important functions. The newer techniques tend to use highly focused techniques which aim at just destroying the cancer cells embedded within the prostate gland. Furthermore, there are drug regimes that are now possible, including immunotherapy. And what this does is to help the body to fight cancer cells by recognizing those cancer cells as being somewhat different and then to kill off those cancer cells. So that really brings me to the end of what I've got to say. But I would just like to remind you, please don't be shy about going to the doctors. Don't be shy about talking to other people, albeit your friends or your colleagues, or to seek out a support group such as Friends and Bredrin. We will support you on your journey through your diagnosis and later if you need us. So I'd like to now end my presentation and to pass over to Royden and also to Joe, who are both cancer people who have lived with it for some time, and they can talk about their lived-in experience of prostate cancer. Thank you.
Thank you, Des. Thank you very much, Dr. Des. That was very, very complete and comprehensive, fairly easy to understand. I don't think myself, it's so brilliant having a medical expert connected with our group, assisting us. That was excellent. So if I can just talk about my experience, how I've come to, well, somebody says there's some things coming up on this. Oh, tell what they are. Anyway, I was first diagnosed in 2013, about the autumn of 2013. I had been having the PSA test that Dr. Des has explained so competently. And I got a PSA test in the middle of 2013 at 4.8. So my GP gave me the DRE, the digital rectal and was not completely happy. It was inconclusive. He said it was my prostate was slightly enlarged, but that was normal for my age. But still decided to refer me to. We discussed it and decided I should have a referral to the urology centre. So I had the rectal biopsy that Dr. Des explained again, and it did. The result did come back to say that I had some abnormal cells there, and they should have another look. So then a few months later, I had a template. No, possibly a year later, I had a template biopsy, and that also confirmed that I'd got the early stages of a low risk, low grade prostate cancer. And I was put on surveillance, active surveillance, because the consultant considered it not to be, things coming up on the screen. The consultant considered my condition to be a less risk. I was less at risk because it wasn't at that time an aggressive form of prostate cancer. I had the Gleason score of, I think, 7. So I was put on surveillance, and then had the PSA done every 6 months after that, thereafter. So in 2019, early 2019, it started going up. Or it had been going up slightly for the previous couple of years. It had risen slightly. But when it got to about 9, approaching 10, I had another template biopsy in early 2019. And our GP decided that, consultant decided that after also having an MRI scan as well at that point, which showed that it was the cancerous cells were contained in the prostate. So I consulted, spoke to me, we had the discussion, and he recommended that I should consider having some treatment to stop the progression, which his recommendation was, after long discussions, was to try some hormone therapy and the radiotherapy. So from June through August last year, April, May, June to August last year, I went through the courses of the hormone therapy, and concluding with a course of 20 radiotherapy sessions, ending about the middle of August last year. Followed 3 months later, in November, the end of November, by a post-treatment PSA, which was quite excellent. So the treatment appeared to be successful, and my PSA was 0.3 at that point in November. This year, I had another one in June, and that was also 0.3. So it all appears that the treatment that I've had has been successful. It's worked, and I'm in remission. It's the condition has been arrested, and I'm due another PSA this month, the end of this month possibly, and we'll see. So I am living proof. Fortunately for myself, as Dr. Des has explained previously, in his presentation. It's sometimes down to a matter of luck. If you actually develop the condition, how aggressive or non-aggressive it will be. And mine appeared to be initially it did appear to be a non-aggressive condition, a low risk condition. And so fortunately it was able to be treated with, and importantly, because I'd been having regular PSAs prior to being diagnosed, it was caught early. So that may have been very, I was very fortunate there. So that is my story, and I'm living away and I'm fine. Just a couple of things I need to add. I have been through this, and you know, my diagnosis and the treatment and all that, without actually displaying any obvious symptoms that you might expect. I had no sign of any waterworks issues, no having to go for to pass water on a regular basis or anything like that. And even through my treatment, that my only slight waterworks or any other symptoms or side effects after I started having the treatment. Some waterworks irregularities, and basically that's it. So it just proves that vigilance, you know, and keeping on top of your health is important, and you do not have to have any symptoms to actually develop prostate cancer. So that is a clear warning that get tested, and also that the earlier that something is found, if it's there, the better the outcome. Thank you. So if I can ask our secretary, Royden, Mr. Royden Allen, who's had a different experience, the other end of the spectrum, and he'll tell you about his experience. Thank you, Royden. Royden, your microphone is off. Royden. Royden, your microphone is off.
Hello.
Hi, that's better.
Okay.
Great, Mr. Secretary, a lot better.
Thank you very much, Joe, for your introduction, and Dr. Des for that comprehensive medical presentation about what the prostate does. And I will just give you my experience. And thanks again, Grace and the CPS, for giving us a second chance. I can remember the first time we were laughing, we were crying because because it was so emotional. I'm going to tell you a story. 2017, I visited my local Jamaican Nottingham, and I usually go there and have my soup.
Royden.
Hello.
Did you say, Royden? Please, sorry to interject, but you meant 2007, didn't you?
2007. Yes.
Yes, you said 17. Sorry.
Oh, sorry. Thank you, Joe. Thank you for that correction. 2007. I went to my local Jamaican restaurant and had my usual, and I saw this. Now, I picked it up, and it basically was saying that I should go and have my prostate tested. So I took the information, made an appointment with my doctor, and went to have my prostate checked. I didn't know where my prostate was. I didn't know what he was going to do. All I knew was these beautiful ladies advised me to go and have my prostate checked. I went to the doctor. I could remember him distinctly because he bought a car from me when I was a salesman. And I says, "Hello, doctor, how are you?" He says, "Come on in." I was dead happy. He goes, "Would you take your trousers off, please?" I go, "What for? I've only come in for a prostate test and a blood test." So I took my trousers off and he gave me a rectal examination. I'm not going to lie to you. I was traumatized. I thought, what is this man doing to me? This invasive examination. And basically, as Dr. Des said, he was testing the prostate. I came out there and I basically cried because I wasn't expecting that. I wasn't expecting a digital rectal examination. And it didn't hurt, but I was traumatized. Fast forward, the blood test results came back. Went to see my doctor again, and he says, "How are you?" And I goes, "I'm fine. You're not going to do another digital rectal examination, are you?" He goes, "No, no, no. But you've got a score of 7. So I thought, what does that mean? He says, "What I'm going to do, I'm going to send you for a biopsy." So made an appointment at City Hospital. And as Dr. Des says, I had a biopsy, which was from the rectum. And they took about 10 pieces, and every piece that was taken, it was magnified. I could hear it. And I was holding this nurse's hand. And I think it was so painful. They gave me a local gel anesthetic to numb the pain. It didn't work. So I was holding this nurse's hand because she was trying to comfort me. And I think I must have broken about 4 fingers because I held on her fingers so tight because it was so painful. And when I came out, I was traumatized again because I wasn't expecting that type of introduction to having a biopsy. So I thought, okay, if this is what I've got to go through to save my life, so be it. The next process is an appointment with the consultant. So I went to the consultant and I walked in. And as soon as I walked in, I knew this man and his assistant didn't have any good news for me because he was sitting, no smile, just a very, very serious face. So says to me, "Hello, Mr. Allen, how are you?" I says, "It all depends. Tell me." So he says, "I've got some bad news for you." My heart sank 1,000 miles. Bad news meaning I've got prostate cancer. So he says, "I'm afraid you've got prostate cancer, Mr. Allen." I took a deep breath and I just couldn't see or hear anything. All I could hear was that was in my head was prostate cancer, prostate cancer, prostate cancer. And I says, "Okay, what next?" He says, "You've got 3 options. You've got go on surveillance. You could have treatment, or you could have a prostatectomy." So there is this consultant asking me, who didn't know where the prostate was, to make a decision on my health. So I says to him, well, how can I make a decision when I don't know this? No, I didn't say it like that. I says, doctor, if I was your father, what advice would you give me? He says, prostatectomy. So says, fine, let's go. That's what I'm going to have. And that's basically what I had. I went to the city hospital and I had my prostate out. As Dr. Day says, there's a lot of side effects when you have your prostate out, but it's still at this present moment in time with the advanced medication, you still can survive and live a happy life. So I had my prostatectomy, my prostate out, and then I had radiotherapy afterwards. Now, the radiotherapy is because the cancer wasn't contained in the prostate. It was on the edges. So I had to have radiotherapy. That's 5 days for 4 weeks. You can't miss a day. Every day you've got to go and have your radiotherapy. And that was absolutely brilliant. I had to wear pads and in a catheter for 2 weeks. And the catheter got infected. Oh, that was so painful, because when a catheter is inserted into a man, it's balloon at the end, or I think a woman as well, it's balloon at the end so that it doesn't fall out. Mine got infected. Had to ring the district nurse. District nurse came. 2 district nurses came. And they were beautiful. And it goes, oh, I'm in pain. Oh, I was in pain. The beautiful nurses took my, catheter out, and replaced it. And it was really, really good after that. In another week's time, they came and took the catheter out. Then I was given nappies to wear for 3 months. Now, the nappies is because I'm suffering from incontinence. The brain wasn't working, got the catheter in, so I'm suffering from incontinence. So that's good. So I was quite happy wearing nappies or pads or whatever you want to, tenor men. And that happened for 3 months. But during that time, I was the current champion of the squash league at Rushcliffe Leisure Centre. So I went to my consultant and says, look, I've got a couple of matches to finish off with. Can I play, although I'm not fully recovered, with my nappy on? He goes, yeah, no problem. So I went and played my game, changed, but I made sure I locked the door so my opponent couldn't see me. Came out, played my game, and I won. And I thought, hey, you did good. You played in a nappy. This guy doesn't know that you've got a nappy on, right? And I was quite happy about that. So wore the nappy for 3 months, and after that there was very little incontinence, but I managed to control it. I was given every 6 months. I was given a hormone injection, as Dr. Des says, and that basically, what the hormone injection does is suppress your testosterone. So there again, your testosterone level is being suppressed. And my PSA was checked every 6 months. Fast forward to 2015, I was swimming, bike riding, running. I was doing good. My PSA started to rise. I was given steroids. It rose, and over till 2018, my PSA went up to 30. So the consultant says, I'm afraid I'm going to have to give you chemotherapy. Ah, that was horrendous. 15 minutes, they put a cannula into your arm to clear the vein. An hour of chemotherapy, and then another 15 minutes to wash it out. I lost my hair. I lost my fingernails went black. I lost all the hair on my head, which I was quite happy about, but I lost all my body hair. My sense of smell, my sense of taste, and I wasn't very well. I had to have 8 sessions of chemotherapy. And after 6 sessions, the consultant says, we've just tested your blood and it's still at 30. So basically, all that pain from the chemotherapy didn't work. So he says, what we're going to do, we're going to give you radiotherapy. So my second session of radiotherapy, which is you've got to go for 5 days regularly, you cannot miss a day, for 4 weeks. And it worked. My PSA was checked regular, and you could see the PSA coming down, coming down, coming down. And my last radiotherapy session, I had a blood test, and it came down to 0.24. So I was very, very happy. So at this present moment, I get a hormone injection every 6 months to suppress my testosterone, and my PSA gets checked. And about 3 weeks ago, my PSA reading was 0.018. So I'm in a very, very happy place. The thing is, where us men is concerned, is very, very frightened, because erectile dysfunction, the incontinent are the major things that men are fearful from. But when you do have your operation, there's this modern advance which is done with a robot instead of a physical man. It's robotic, and they do a thing called nerve sparing, and that can actually help with the erectile function. It's not guaranteed, but it can help. Some people, it doesn't work. Some people, it does work. So if you're lucky, you'll be able to have some type of sexual exercise with your partner, wife, or whoever. Sometimes you might not be able to. But the main thing about it is you are alive. And at this present moment in time, for me, I swam 1/4 mile yesterday. I rode 7 miles with my friend. I go walking like Joe does, like Dr. Des goes walking and cycling. And from 2007 to now, I've celebrated my 13th year as a survivor. So I would encourage, as Dr. Des says, the women as well, encourage your men, your brother, father, to go and have a PSA test, because it might one day save your life. Thank you.
Thank you so much, Royden. You have been amazing. I think you're an amazing human being, and you know, I think we should give you all a big clap. If I may request everyone, please, to give everyone a
Can I just? Do you mind, Inda?
No, please do, go ahead.
and everyone present. Royden Allen is my hero. Royden Allen is, for what he's been through, the example that he set and what he's doing and the work the work that he puts in with this group. It's amazing. Thank you, Royden.
We are so grateful to you. We are so grateful to you. Thank you so much for being so real and so willing to actually talk about your journey, because it's not an easy thing to do, to have to relive all that. And we're so grateful to you for, you know, being so open and so courageous, both in going through the treatment, but also in being willing to share your experience with us, which is no easy thing to do when you've been through so much. We're so grateful to you. Thank you so much to all of our guests today for you know, sharing with us your experience, your lived experiences and your knowledge. And I'm just quickly going to go through just some of the comments that have been made, which are very supportive. At the beginning, Grace, our chair, she said she's shocked to know that a GP can actually refuse to test you for prostate cancer, which is really not really acceptable, I think. And you know, please I'll just go through the comments, and then if there's anything you want to pick up on, please do so. You know, and I think Pauline is basically saying that that it's very off-putting, you know, when you've kind of mustered the courage to go along, and then you know, if you're refused, it's not good. A big thank you for Polly to Des. Janet Morris is saying that she's surprised that wide automatic screening isn't yet available. That might be something that Des might want to come back to in a little bit later. Thank you for providing such a comprehensive medical explanation about prostate cancer, Des. So that was for you. This is Grace again. The link to sexual ability will be a big issue for men in communities where virility is seen as a key aspect of masculinity. This is why it's important to challenge gender stereotyping in our communities. A very important point made by Grace. Meredith Collins is saying that, Des, are there certain foods that should be avoided or indeed eaten to assist? So if you could make a mental note of that. And also a comment from Des responding, yes, loss of sexual function inhibits many men from going forward to be tested for prostate cancer, but the sooner it's caught, the better is the prospect of maintaining good function. Something else from Des, perhaps I can briefly talk about diet if we can have time, and also to mention COVID vaccination if possible. Thank you for that. And this is Jeff Carr. Good to know you got the post-treatment PSA and to keep an eye on that. So great, fabulous news from Meredith to Joe. Holly Davidson says that her dad was diagnosed just over 3 years ago. Unfortunately, this was advanced and he has undergone various treatments since being diagnosed. It's very comforting to hear your experience, Joe. So please you're in remission. Something for Royden. This is Jeff Carr. Your story of your first examination reminds me that when I went to donate blood one time, I was waiting for the results of a PSA test. The doctor in the donor centre said that a blood test was not the best way of checking for prostate cancer and was advocating a digital examination. I told him if he thought I was going to have a digital examination before each time I was going to donate blood, he could cross me off the list of donors. Grace has given a very big thumbs up. Royden, your story is making me laugh and cry at the same time. And so thank you for sharing such a traumatic and personal journey. Janet Morris is saying it's great to hear the promotion of testing and being provided with the information that makes this achievable. Lost one of my oldest and closest friends to aggressive prostate cancer that was not diagnosed in time. He was given 12 months max to live, but managed 24. A great loss to us personally and the community he represented. Thank you for providing advice on gaining the test. Big thumbs up from Holly. Royden, you're amazing. The way you tell your story is so inspiring, and I love the comedy you add to it, but very real too. Conrad is saying brilliant news at the end of a very challenging period. Janet is saying very inspiring story, amazing Royden. Lots of amazings. 13 years, that's long time. Thank you both. Royden, thank you for your speech. You're an amazing man, like you said. Thank God you are alive. And then Conrad has said that has actually brought me to tears. So my brother-in-law has just started that process and is quite worried. So Anthony is saying thank you, Royden, for sharing. Jonathan, thanks for sharing, very inspirational. William, thank you for your sharing. We'll spread the word. Chanjit, thank you for sharing, Royden. You're an incredible person. Grace St. Louis, thank you for sharing inspiration. Grace Moran Fulu, our chair. Dear Royden, dear Des and Joe, thank you for sharing your stories with us. These testaments are so important to us to put some context to this awful disease. Holly says that any advice on how to support male family members in relation to this mental health through diagnosis and treatment would be so helpful. Back to Jeff, Royden, you talked about hormone therapy. Have you had problems with breast development? My dad had hormone therapy and developed breasts. Pauline, very courageous, thanks. For sharing your story, Royden. The humour does help. So I think, if I may, there's some queries for Des. Des, may I just pass over to you?
Yes, of course. Thank you, Linda. There's a few questions there that I'd like to respond to, and not necessarily directly in order, but the person who just asked about support, mental health support for a father. I don't know whether the father already attends the support group, but I mean, today is testimony. When you hear Joe's, when you hear Royden's story, you know, there's one word to describe them, and that's superhuman. There's real love in our group. And I would urge your father to consider joining a support group. And they do exist now. There's an increasing number of support groups nationally. You can even join our support group virtually. You know, we do hold sessions whereby, because of COVID, whereby you can join in, and Royden hosts support groups, but he's a pioneer and he's an inspiration to us all. The other thing that...
Thank you, Des. Thank you.
That's all right. The other thing that can be done is you can talk to your GP or a specialist nurse, such as a Macmillan nurse, about mental health. And you might be able to access free counselling. We certainly have a very good relationship with Macmillan, where we are in Nottingham. They're very supportive of us, and we help them out as well. And they provide free services. Another route to consider is to go along to a hospice. Now, I know some people have a fear about hospices, but they do tremendous work. And also because they tend to be voluntary, but also some receive a portion of money from the NHS, and it allows them to employ counsellors, you know, to deliver various services, including mindfulness, mental health services, yoga, and various other activities. And so there's a real good social community that can be developed and had in those places.
He does have support with the Macmillan nurses. I just think he could have the extra support of probably men who are going through it as
Yeah,
well. So I
definitely.
think you would love Royden.
Yeah, yeah.
I'll definitely pass this on to him.
Yes,
He would absolutely, he'd
great.
really love it.
Yeah, great. Please do, because there is real comradeship within the group. And, you know, because the majority of men who attend the group, it's a bit historic, you know, they've had their treatment, they've gone along and they're at different stages, and they share information and say, well, actually, here's a practical tip. You know, this is what works for me. You're not just getting one person's view, you're getting a consensus, you know, from a different number of people.
Yeah, that's
And so
really
it gives you hope of, if one thing doesn't work, try something else until you find something that works for you. So it's a wonderful group to be part of. I get a lot from attending and seeing, you know, being a part of this magnificent charity.
It really does sound amazing. Thank you.
Okay, can I move on to answer some of the other questions? There was a question about diet. I suppose we can frame that in the wider context. What causes prostate cancer? And the simple answer is we don't know. Now, as a medical scientist, my group are involved in looking at gene studies and protein studies, identifying different populations of patients. So we've taken men of African descent, compared their DNA to that obtained from white Caucasian patients, and we've looked for differences, and we have found a number of genetic differences. One big factor tends to be the way our immune systems develop and respond later on. And we're not alone in this. There's a big group in America who have come up with similar findings as well. And so I'm now going to relate that back to the question about food. Is any particular food going to be beneficial in either trying to prevent prostate cancer or helping you to avoid going down that really aggressive cancer route? You won't be surprised by my answer, I think. A good, healthy lifestyle is important. So if you're overweight, if you can shed some weight and try and get your BMI, your body mass index down. If you're obese, so that's a BMI of 30 or over, try and bring it down, because a lot of people probably know that people of African descent have an increased predisposition to become diabetic, to have high blood pressure, and some of these metabolic diseases. And some of it is due to lifestyle. Some of it is due to having certain genetic changes. Okay, so I think with blood pressure, when you're trying to treat blood pressure, your doctor will be very aware, and they will ask about your heritage, because that can also influence what treatments they give. So, a healthy lifestyle, incorporate fruit and vegetables, of course. There is a suggestion that red fruits, because they contain a chemical called lycopene, this can be preventative of cancer formation. Also, foods that are rich in zinc can also be beneficial because they promote the immune pathway. And as I said, in the more recent studies of some of the immunotherapies that are being developed, we found that it can be very important. The host can actually cure itself of cancer. But that's not to say if you develop cancer, it's some sort of willful failure. It's not at all. I just hesitate when I hear people talking about battling or they've lost the war with cancer, because it's nothing the individual is doing wrong. It's just biological often. Okay. I would restrict the amount of red meat that you eat. Don't overindulge. Don't overindulge in processed meats, such as ham or those that contain a lot of salt and phosphate. Try and limit the amount of dairy food as well, because there are some association studies that say, you know, people who have a diet rich in red meat and dairy products are more likely to develop certain types of cancer. But this kind of study is very difficult to prove one way or another. So generally, try and keep healthy by getting regular exercise, eating a varied diet, rich in fruit and vegetables. Moving on to the question about whether your GP can refuse to give you a PSA test. The important document is that Public Health England document that I referred to. If you have problems with your GP directly, the route is to go, first of all, to the practice manager and ask whether you can have a consultation or a second opinion with a different GP. If you still hit a brick wall, then you can go to the local commissioning. It's called the Clinical Commissioning Group. And that's a body that works with the local councils. And so if you type in Clinical Commissioning Group and have a conversation with them or write a letter to them, and they will take up the case. Alternatively, go to a charity such as Macmillan and speak to one of their specialist nurses, and they will guide you through the process of actually complaining or trying to get access to the test that you need. Okay? And that's, I'll stop there to allow other people to either ask questions or comment.
Are there any questions anybody has? If you have, please could you put your hand up? Okay, looks like Jeff Carr. Thank you, Jeff.
Hi, I don't know if this is a question to you, Des, or
Okay.
maybe it is. When my father had prostate cancer, he'd had a TERPS, and then he had to go. It came back, and he had to go through the radiotherapy stuff. And I remember it was going every day, 5 days a week. But I think he was going for about 10 weeks.
Yes, 8 to 9 weeks is common. So okay, 10 is not out of the ordinary.
When Royden said he was going for 5 weeks, I was thinking, oh, he got it off lightly. But then I thought, has the technologies progressed more recently? Because my dad, it would have been, I guess, probably about the end of the noughties, so 2008, something like that.
Yes, I would say it has. And now higher doses, what's happened, there's been a number of clinical trials in a lot of different cancers, breast cancer, prostate cancer, looking at whether it's better to give a lower dose of radiation to try and minimize the extent of local damage or collateral damage to tissues close by to the target organ, whether it's better to give a lower dose but for a longer period of time, or whether to give a higher dose but over a shorter period of time. And looking at the end results, with it being a clinical trial, what tends to happen is they take 2 different populations or cohorts of patients. They run equal arms, for the same number of patients in each group, and then subsequently they have to wait a period of time afterwards for the results to see what happens. Now, with a disease like prostate cancer, where you can have a relatively low stage disease and you can go for a decade or more without any further advance or progression in that cancer, you can imagine that the time after the clinical trial can be quite a long time before you get the full set of results. But I would say, generally speaking, time is coming down and dose is going up to be equally effective. So yes, time is coming down for treatment.
I know he got his bladder burnt by the radiotherapy, and so he was going up to be checked, and by the end of he wasn't told about this as a possibility, and he said he wouldn't have started it if he'd known it was going to be a possibility, because he ended up knowing where all the public toilets were, all the pubs and with toilets in between home and the hospital, because he was getting caught short all the time by the end of it. There was just one other thing. I mean, talking about PSA levels, and I know they're very low, and then it's how quickly it rises. A colleague of mine said he got prostate cancer, and his was up in the thousands.
Yes.
And I was shocked at the time. But when you hear Royden talking about his being at 30, and it's a significant jump, but then when you hear about other people and there's a way up, does it mean something different in terms of the cancer, or
yes, it can do. And so as I said, the PSA is a protein that's made by all prostate cells, whether they're normal or they're cancerous. So healthy men who haven't got any evidence, diagnostic evidence of having prostate cancer, we all have PSA in our blood. Okay, it spills over into our blood. So generally speaking, the higher your PSA level, then the more aggressive the cancer tends to be. And that's because, if you can imagine, if each individual prostate cell contributes a little proportion of PSA protein into the blood, in order to get such a high concentration, so you're talking about 2,000 or 3,000 nanograms, you just said, which is 2 or 3 micrograms. If you get that level of concentration, then it either means that you've got a very large number of cells, prostate cells, which are producing it, or those cells have got a very rapid metabolism. They're producing the protein like crazy. And what tends to happen is it's a mixture of both, actually, in that in order to produce that concentration, with a cancer is an uncontrolled cell proliferation or multiplication of cells. And so those cells are dividing. And in late stage cancer, the cells actually leave the prostate gland, they metastasize or spread to other tissues and other organs, and they seed, and then they start to grow. And so common areas are the spine, in the thigh, so the femur, in the hip, in other organs within the pelvis. And so that's another important symptom to look for. If you get into your 40s, or if you get into 50s, and you start experiencing these pains, and especially if you've got a father or a brother who's had prostate cancer, then please go and talk to your doctor about it. It might be nothing. It might be musculoskeletal rather than a tumor, but it is worth getting checked because of that. So generally speaking, though, yeah, the higher the level of PSA, the higher the probability that there's cancer cells growing and proliferating. I know from a discussion with Royden just recently that one of our colleagues, one of our members, gave the first presentation or the previous presentation to the CPA, and sadly, our member passed away this year. And when he went for his PSA test a couple of years ago, his PSA was in the 2000s, and he was told that he had 6 months to live, and he survived for a couple of years. But sadly, we lost him this year.
My colleague's still around, and I think it's been 4 or 5 years since he was told. So
yeah, but hopefully he's received treatment. And his PSA has come down now.
Yeah, hopefully.
Yeah. Good.
I haven't
Good.
talked to him about it since. But... Okay,
Okay.
thank you.
Okay.
Thank you. Thank you so much. That was very, very helpful. Anything else? Just I'll take one more if anybody's got any other question, and then I'm going to pass over to our chair, to Grace. Okay, thank you. Thank you so much. And now over to our chair, Grace.
Thank you so much. I just want to say thank you so much to Friends and Bretrin, to Joe, Dr. Des and Royden. An extremely powerful and emotional testimony about how important it is for men, all men generally, to get themselves checked out. I thought this was a really important issue for us to discuss during the Festival of Inclusion, because I personally feel that often gender and well-being is often lost when we're talking about issues that impact our health. And I know it's very, very difficult for a lot of men to even go to the doctor without a lot of nagging or being, dragged by their wives. And I remember the very first time I had the presentation from Friends and Bretrin around 3 years ago in the CPS East Midlands. All of us women in the audience were horrified, and I know that every single one of us dragged our husbands by the hair to the GP for an appointment the following day, because it's something. I just think it's such an interesting issue that people don't think about men's health and all the fragility that's linked in with that, about masculinity, about not wanting to go to the doctor. And I know I shouldn't be saying this, but my partner is very ill at the moment with a very bad cold, and I've been screaming, "I want to call the ambulance, etc." But why doesn't he just go to the GP without me having to drag him by the hair, so to speak? But I think I'm not saying it's a masculine thing, because I know not all men have that issue, but it's so important for us to raise awareness and discuss the impact of not taking our health seriously, or not feeling that certain issues are worth taking the risk of going to the GP, particularly around the issue of sexual matters as well. Really important. So thank you so much for having this discussion with us. We're very grateful. I know we've gone over time, so I'm not going to say much more than that, but I would like everybody to put your cameras on if you can, and give these wonderful gentlemen a round of applause to show our appreciation. So if everyone could put their cameras on and give them a round of applause. Thank you so much.
Thank you. Thank you,
Thank
Grace.
you.
Very, very grateful. And thank you all of you for your cameras on. Wonderful, lovely to see you all. Very, very grateful. So thank you everyone for joining us. I'm so sorry we've run over. If you have any questions for the Fab guys, we've got some contact details which we'll share. Joe, did you want to say something?
Yes. Is it Joe or me? Joe?
Thank you so much for the invite for today. It's been an absolute pleasure.
Brilliant. Thank you so much for honouring our invitation. It's lovely to have all of you. Joe and Royden, thank you so much.
Grace, can I just say one thing?
Yes, of course.
Yeah. We have got an affiliation form, and obviously we depend on donations. So if anybody is interested in being affiliated to, do you want to describe that, Des?
Yes, can do.
Yeah, go on then, please.
Okay, thanks, Royden. We Friends and Bretrin are entirely run by volunteers. Okay, and so the only funds that we receive is through by people making a donation to us. And with it being COVID, we've suffered this year in that we've not been able to do our usual sponsored events, and so we've not been able to get the funds that we usually attract. Grace has very, very kindly agreed to send out our leaflet, on which you'll find contact details. You'll find an email, you'll find a phone, you'll find web details, so an address for our website. Can I please urge you to consider taking these leaflets or requesting more from us back into your workplaces, so that you can pin them onto the notice board, or you can raise the subject in conversation with your friends, your colleagues, whatever, your family. And also, please consider either making a donation or affiliating to our small charity. And if you want an affiliation form, I'd be only too happy to send one along to you. So you'll get our contact details. Please don't hesitate to contact us with any questions or any concerns. For any further information, we're just here waiting for your call or whatever. Okay, thanks.
Thank you. Thank you so much. we're going to send the leaflet out to everyone who attended today, along with the bank details, if that's allowed. So people can make a direct donation if they choose to.
Yes.
Okay,
please do.
Thank you. So thank you everybody for taking time to share with us this wonderful event. So hopefully we'll see you at our next event on the 8th of December with Mike Driver. So thank you so much, everyone. And a lovely thank you to Inda as well in the background, doing all of the hosting and recording. Thank you, Inda. You're a superstar. So thank you, everybody. And I shall see you all again soon.
Thank you all.
Bye.
Bye.
Thank you.
Bye.
Thank you very much. Bye-bye.
Absolute pleasure.
Thank you.
We've enjoyed it.
Thank you.